Здравствуйте. My name is Dr Pikija, and thank you for having me here. I'm excited to be in this lovely city of Almaty, Kazakhstan. Some few words about me. I'm working 20 years in the field of neurology, last 15 years in the field of stroke neurology. Currently, I'm in charge of the stroke unit, the one of the biggest in Austria. I'm in charge of 14 stroke beds. This is one acute station, and we have capacity of 1 day turnaround of 7 patients per day. So we are having 7 patients, and we can treat all of them with modern therapy. And I can say my peak performance was in 1 day 5 thrombolysis and 2 interventions in 24 hours. So we can say we are high through output center. So I'm hoping that I can give you some of my experience, also as a physician and as a human, because I changed already 5 stroke units in my career. So I've been working in different environments. So today we have something to do. I would like to talk about early neurorehabilitations, about components thereof, and about possible adjuvant therapy. So Austria, this is my clinic. It's pretty gross, a bit big. We are having catchment area of 800,000 people. And I want to discuss shortly how it is 1 day to be a stroke patient in Austria. So all starts with one call from physician on the field. So they are calling us, our center. They are giving us vital informations and mode of transport. So we are having average 4 helicopter transport per day. This is mainly cerebrovascular patients. Others are coming with ambulance. This is due to geographical constraints of our country. So before patient comes, he or she can be fully admitted to hospital system. And we have no administrative delay. The patient is transferred directly to the emergency unit, and we are capable of average time 5 minutes for blood withdrawal, ECG, blood glucose, and coagulation test. So I'm having vital parameters with on-spot laboratory in 10 minutes. So after these 10 minutes, we are going to CT suite with the patient, and we are mixing the drug RTPA, Actilyse. We are mixing the drug and there is no blood in the CT, we are giving RTPA intravenously. Afterwards, angiography is done. When patients had vessel occlusion, then it is from CT suit directly transferred to the angio suit. And mostly procedure thrombectomy is done under general anesthesia. So afterwards, patient come to intensive stroke unit. This is also my workplace, where we are having multimodal possibilities of monitoring and also early rehabilitation. So this is my stroke ward. This is my intensive care unit. And this is the room where we are doing sometimes thrombolysis also. After thrombolysis or intervention, patient undergoes almost immediately multimodal rehabilitations. So we are lucky to have all modes of rehabilitation in our clinic. So we are having ergotherapy. So this is with the hands. You are doing rehabilitation of hands. We have physiotherapy and speech therapy. So these three modes of rehabilitations are administered almost immediately upon arrival. It's interesting to know that we can give rehabilitation 7 days a week. So rehabilitation specialists are having on-call duty also. So then there is no gap. So as already know, stroke is the most common cause of long-term disability in adults. And most importantly, almost the second one, 40% to be exactly, will be left with moderate to severe impairment. And this imposes burden to society in general. So I've done some research and I'm seeing that Kazakhstan is so lucky to be in the group of countries. It knows so many geriatric patients. We are one young country with young population. But the majority of the world, this is not so. And this demographic picture will change. So we should, as health policy makers, we should be prepared for the demographic shift. And we should plan strategic for future. Okay, so stroke unit model or the stroke unit paradigm is proved to be efficient way to manage stroke patient. Also forms the key basic measure of stroke service quality. So when you want to have a stroke unit in your hospital, you should be able to compare yourself with your quality measures with reference center. And this is the key point. You should always adjust yourself to the reference center. And what are the key messages here? Time to CT, so how long you need to bring your patient from emergency unit to CT. time to thrombolysis, time to intervention, and patient outcome. So you should always, when you are establishing a new stroke unit in your hospital, you should compare yourself. And you should have certification for a stroke unit. Certification could be given to you from an outside body, from a government body. This is the best way to do it. So we see it. This is a huge discrepancy here. How many patients are treated with reperfusion therapies? So in Europe and worldwide, we can say that 20% of patients could be averagely treated with reperfusion therapies. European average is lower. So we all worldwide have a work to do. I have to do both ways. So we are also lucky to have automated monitoring. So when nurses in my unit are sitting, there is one large monitor, and each of these 14 patients had vital parameters constantly recorded. Blood pressure, heart rate, and oxygenation. And I'm so lucky that I can review the last 48 hours of ECG recording. And I can tell you that this possibility is a game changer. Because after each visit, each day, my group and I, we are going to this monitor, we are reviewing ECGs from each patient, and we can detect de novo atrial fibrillation really, really often. So I could say 1 per week newly detected atrial fibrillation. So this is a game changer for the patient. We also detect, for example, ventricular tachycardia, and so on. So when you can do it, I will recommend it. It's important to know that all age groups benefit from the stroke units. So there should be no reserve for admission. Again, I'm so lucky to work in one environment where treating 16 years old, so children with cerebral venous thrombosis, and our population goes until 110 years, 110 years. And what is important to know, TEAs should probably, all of them should probably be also treated on stroke unit. This is now the good time to talk about days in hospital, days on the unit. We are having averagely 3 days per patient in stroke unit. Then they are transferred to phase B rehabilitation bed, where they are staying 14 days, mostly. Then they are transferred to phase C bed, when they are staying up to 1 month. Let's go. Oh, this one. Okay, yep. So this is one suite on room where ergotherapy is administered to the patients. I'm not sure if you can appreciate it, but they have a multitude of options to train the fine motoric of the hand. Occupational therapists are coming to the patient also, to the bed. They're assessing with standardized questionnaire the function of the upper extremity. Peg hole test, for example, you know, peg hole test. Okay. Then they are producing one structured report. We're all discussing it one day in the week together to set the goals, to adjust the goals, rehabilitation goals. So we are administering in my unit early rehabilitation. Okay, this is our standard. But as already you may know, there is one award study recently published that spoke against ultra early mobilization. So we should know mobilization sometimes had nothing to do with rehabilitation. So I will not change my my work only upon these Avard study results. You should know that Avard study had many critic points also. I'm not sure if you're familiar, but there were only 6% patients screened in the Avard study that were actually included in the study. So I will recommend ultra early rehabilitation, but not necessarily mobilization. And I will recommend mobilization in first 24 hours, not for the patient with bleeding, intracerebral bleeding, or severe stroke. Okay. Good. Okay. So also, as you already know, multidisciplinarity is the key of the recovery. So human being, we can say, is also multidisciplinary. So they are having speech, we are having speech, they are having motor functions. So how can we promote this? So we could first set realistic goals. What can be achieved? Then we can go one step after the other. And really important, adjust the rehabilitation during the process. And feedback between neurologist, physiotherapist, occupational therapist, and speech therapist is really important. Again, I'm so lucky to work in such an environment that had something like this. This is Locomat, so name. All of the body can be put in one constraint and they can walk together with the machine. So okay. So which stakeholders we have? So neurologists, psychiatrists, really important in my unit also. Rehabilitation nurses, physical occupational therapy, speech language, and so on. I will emphasize this one. I'm not sure whether you are having structured swallowing test in your units. Speech therapists can help you with this, because I'm aware of the many studies that showed that bedside swallow test influences outcome of the patient. And after this test, we can contact the dietitian, and the dietitian could say us how this patient should be further treated, what should be given. I think social workers, really important, not to underestimate case managers. I do not know whether you are having this case managing in your environment, but it is really important to have one because of geriatric comorbidity. So ultimate goal, as I said it, is really important and aim to improve function by allowing stroke survivors to operate as independently as possible. Okay. So comorbidity. This is the theme that we are assessing each day on our unit. We are having special protocols for decubitus management, for skin sores. We are lucky to have special mattresses because this could be a real big problem. When one arrives, when decubitus is diagnosed, we are having special nurses that are capable of dealing with it. So they are coming to my ward. These nurses, wound management nurses, they are coming. They are assessing the situation and making recommendations. Contractures, really big problem. Shoulder contractures also. And as we may good know, use of ankle arthrosis is recommended in this setting. Okay, so one question to audience. Do you know what this is? So this is one piece of equipment in my intensive stroke unit. So in ICU, neurological intensive stroke unit. So and it is on the top. And we can, on this piece of equipment, we can hang one, how should we say, on chair. We can lift patient from the bed to the bath. So when I first saw it, I was there's really something special, I could say. So why is this so important? Because we have, when we see it, and patients are dying from pulmonary embolism. They are dying on my unit, and they are dying everywhere. How we can manage it? In my unit, I think all patients, virtually all patients, are given enoxaparin or dalteparin. I mean all patients, with bleeding also. I think only excuse will be acute bleeding under oral anticoagulation medication. Only excuse not to give it. However, it is not 100% protection. When you can afford pneumatic stock compression, this will be also a good option. This will be a good option to do it. So the next slide will be about aphasia. About aphasia, so speech difficulty should be done in 12 weeks. And treatment should include communication, pattern training. When you have possibility to do it with a computerized treatment, probably it is good to do so. Why? Because we are not having always enough speech therapists. And in this particular setting, they can be replaced with computerized treatment. Okay. So, we are moving on to spasticity. Affects up to 43% of stroke patients. Yeah. And when present, cost of the management of care is 4 times higher. So, huge problem. What we are doing in Austria, we are liberate of administering botulinum toxin. So we are doing these applications on a regular basis. We are also lucky to have epidural botulinum toxin pumps, so applications epidural. We are having regularly 10 with 20 patients on this therapy. I should say mainly in multiple sclerosis patients, but also in stroke patients. So we're moving on to mobility. Okay, so this is also one place in my rehabilitation unit. So as you can see, the patients are having a lot of training possibilities. So what are the key training parameters? Should be done at appropriate time after strong consent. Should include treadmill, circuit training, and sometimes electromechanics assisted training. So this is really a super thema. You already saw this locomat, okay? When you can afford it, this is really for patients one big thing to do. So, okay, so upper extremity activity, we can say it is encountered in majority of stroke patients. And because of this, they're losing activities of daily living. And I can say that constraint-induced training will possibly make a difference in the future when it will be more applicated to the patients. It is already shown that constraint-induced training make a difference. Robotic therapy, on the other side, is this moment experimental, but with big potential. So we are coming slowly to additional pharmacological interventions. I will go quickly through it. We are having some evidence about fluoxetine. They can help to recover after stroke. They can make it faster. They can make it better because they are influencing neural networks. They're influencing plasticity, and they're influencing the balance in neurotransmitters. So as you can see, we are having many options. Only a few of them have been proven successful. So, okay. The first one was average trial collaboration group, fluoxetine. My colleagues in my age possibly know this drug, possibly one of the first SSRIs, I think, selective serotonin reuptake inhibitors. use of robotic devices can improve recovery also. Last but not the least, also cerebrolizine recently, 2015 stroke publication, multi-center study, significantly improves motor function during early rehabilitation after stroke. So we can say we have options. So we have rehabilitation specialists and we have pharmacological options also. So this is, I think, a AVERT trial that showed efficacy of fluoxetine. So what is special about this trial? The trial included moderate to severe patients, and fluoxetine showed efficacy. However, at this moment, there is not enough evidence to recommend it by class 1 evidence in the recent stroke guidelines 2018. So then we are going to CARS. This was phase 2 trial, 208 patients, 3 lens. So in this dosage, 30 milliliters per day, I'm using it regularly at my unit also. So patients are coming after treatment, after acute treatment, from CT, from lysis, from thrombolysis, and they're giving cerebrolizine 30 milliliters up to 21 days intravenously. Our experience is terrific. It's really good. No safe concerns with cerebrolizine up to date. We are using it, I think, in my unit 30 years already. Okay. So Muresanu, the author of the paper, used ARAT tool to show that cerebrolizine brought the change to the patient in a positive way. We can see 24 points change, better change compared to placebo. It could be also translated to this score, and we are seeing it constantly from day 14 to day 90, constant improvement, already beginning of 2 weeks. Okay. This could be also translated to the most popular outcome scale today, modified ranking scale. Well, we can see the cerebrolizine had a much larger proportion of patients in score 0 and score 1. And we are coming to the end of presentations. Key points, take-home messages. You should do it when you do it, no rehabilitation, you should do it already on the stroke unit. When you have capacity, personal capacity, personnel, then that should be done in multidisciplinary team. However, this is not the only option that we have in neurorehabilitation. We could also use pharmacologicals such as fluoxetine or cerebrolizine. So thank you. I will take the questions. Thank you.